So we're going to go ahead and move into our next session, which is on irritable bowel syndrome. And again, like the short bowel syndrome session, we will be having a physician begin, and then we'll be followed with two patient stories. And so the physician for this session is actually going to be Chang, who is here with us today. So we're lucky to have her for the question and answer session afterwards. And she'll do an introduction about irritable bowel syndrome. And then she'll be followed with two patient stories.
And the two patients that are going to share their stories about having IBS, one is Deb Caton, and she has IBS with constipation, and then Lisa Strykowski, who has IBS with diarrhea. And they're going to tell their journey of how long it took for them to get a diagnosis and treatment for their symptoms.
Hello, I'm Chang, and I work at UCLA, and I'm very honored to be able to speak at the IFFGD 30th anniversary. And my talk today is Physician Introduction to Irritable Bowel Syndrome. Next slide. So the objectives of this fairly concise talk are to define irritable bowel syndrome, or what we know as IBS, to review the diagnostic approach to patients with irritable bowel syndrome, and to briefly discuss the pathophysiology of IBS and review the treatments for IBS with diarrhea, which we call IBS-D, and IBS with constipation, which is referred to as IBS-C. Next slide. So this shows the key results of a study done by Ollie Paulson and others, where the prevalence of functional bowel disorders, which we now call disorders of the gut-brain interaction, were assessed in the United States, Canada, and the United Kingdom. This was using the Rome 4 criteria, which is a little bit more strict diagnostic criteria. But what you can see from this study is that 1 in every 4 adults in these countries has one of the 6 functional bowel disorders. And the pie diagram shows you these different functional bowel disorders. IBS, that comprises almost 5% of the population, functional constipation, functional diarrhea, functional bloating, opioid-induced constipation, and unspecified bowel disorder, which means that the patient has chronic bowel symptoms, but it doesn't quite meet the symptom criteria for these other defined conditions. Functional bowel disorders are more common in women than in men, but they can occur in both gender. They become less common after midlife. And I'm going to tell you more about them in the next slide. So these are key organic diseases that we think about when we're assessing the differential diagnosis for IBS. And many healthcare providers are always concerned they're missing some other diagnosis that explains their symptoms. And these are some of the main organic diseases that we think about: colorectal cancer, inflammatory bowel disease, microscopic colitis, bile acid diarrhea, celiac disease, food intolerances or sensitivities, congenital sucrase isomaltase deficiency, and small intestinal bacterial overgrowth, which is known as SIBO. Next slide. So since IBS is really a symptom-based diagnosis, this is a diagnostic algorithm that we often go through when we see a patient with IBS symptoms. So we always start off on the left upper box with the symptoms, because that's really what the patients present with. So patients who have recurrent abdominal pain that's associated with defecation and or disordered bowel habits are the main key symptoms of IBS. And when we see them, we do a medical history, includes surgical history, psychosocial, dietary, medication history, do a physical examination, and a digital rectal examination is important in these patients as well for a number of reasons, looking for a rectal mass or for pelvic floor dysfunction, particularly in patients with constipation. We also assess if the patient has alarm features. And the alarm features are important because if the patient has alarm features, which I'll describe in a moment, we might do more specific investigations than we normally do if they don't have alarm features. And I want to show you what those alarm features are. So next slide. So these are alarm features that are more indicative of having an organic GI disorder of the a structural disorder or biochemical disease, inflammatory bowel disease, celiac disease. So the alarm features for IBS symptoms are symptom onset after the age of 50. Now, this is new symptom onset, not an exacerbation of symptoms, but they've had symptoms earlier in life. It's new onset after the age of 50, unintended weight loss, so they're not on a diet, of at least about 10% of their body weight in 3 months, rectal bleeding that is not caused or confirmed by hemorrhoids or anal fissures, or if the patient has melena, which is black stools, nocturnal diarrhea, waking up in the middle of the night to have bowel movements and diarrhea, fever, family history of colorectal cancer or polyps, inflammatory bowel disease or celiac disease, and unexplained iron deficiency. Those are the alarm features that may take us down a different path, diagnostic path, than if they didn't have it. Let's go into the next slide. So this is just showing, again, the algorithm, but if a patient does not have alarm features, there's limited screening tests that we can do. And this shows you on the bottom table a lot of the culmination of a lot of different guidelines around the world on the diagnostic evaluation of patients with IBS symptoms without alarm features. And you can see that we do order for patients with IBS with diarrhea symptoms, celiac serologies, fecal calprotectin, C-reactive protein. We can consider bile acid diarrhea testing, Giardia stool antigen in the United States, because Giardia is prevalent. And in patients with constipation symptoms, we may consider an anorectal physiologic testing for dysenergic defecation. It is not currently recommended to do routine stool testing for infections unless there's a history to suggest they have an infection. Routine colonoscopy under the age of 45, food allergy or sensitivity testing, or lactulose or glucose hydrogen breath testing. Now, we want to do routine colonoscopy just by the guidelines that we have, but that's in all individuals. You don't have to do anything different specifically for patients with IBS symptoms if they don't have alarm features. Next slide. So if the patient has had these limited screening tests, they don't have alarm features, it's negative, and then we look to see if the patient meets the Rome-4 criteria for IBS, which is abdominal pain at least 1 day a week in the last 3 months, and the pain has to be associated with 2 out of the 3 features, or at least 2 out of the 3 features. Related to defecation, so the pain gets better or worse after a bowel movement. The pain is associated with a change in stool frequency, having more bowel movements per day or less bowel movements per week. And the pain is associated with a change in stool form, loose, watery stools, hard, lumpy stools. The patients have to have these symptoms that have started at least for 6 months ago, but they're more active in the past 3 months. Next slide. So let's get back to our diagnostic algorithm. We did limited screen tests, they're negative. They meet the criteria for IBS. And then we tried to subtype the IBS by bowel habit predominance, IBS with constipation, IBS with mixed bowel habits, IBS diarrhea, or IBS unclassified. That means that the patients have pain that's associated with defecation, but when you really look at the stool form, neither of the 2 extremes of stool form are really predominant of at least 25% of bowel movements. Next slide. Okay, so we use the Bristol Stool Form Scale to define IBS bowel habit subtype. We want to do the bowel habit subtyping because a lot of the treatments for IBS normalize stool form and bowel habits. So we have the Bristol Stool Form Scale, widely known as 7 different types. This is the range which we see in the general population. And we define IBS-C and IBS-D and mix by the predominance of the stool type. Next slide. So for IBS with constipation, the patient will have at least 25% of their bowel movements, hard, lumpy stools. And this correlates with slower transit time through the colon. And they have less than 25% of the loose, watery stools, which is type 6 or 7. Next slide. Now, IBS diarrhea, on the other hand, at least 25% of bowel movements are loose, watery, the type 6 or 7, and less than 25% are the hard, lumpy, drier stools, type 1 or 2. And IBS mix, as you can see in the next slide, is really a combination of both extremes. At least 25% of the bowel movements are type 1 or 2, and at least 25% of the bowel movements are type 6 or 7. And this Bristol stool form scale does correlate with transit time. The type 1 or 2, the constipation type, means that the stool moves through the colon slower. And the type 6 or 7 stools, loose watery stools, the stool moves through the colon faster. Next slide. Now we know that there's a spectrum of bowel habit, these different disorders of gut-brain interaction or functional bowel disorders. If you look at the x-axis, that's the scale of pain. So if you move to the right where the patients have more pain and they have bowel habit abnormalities, they have IBS or could have IBS. On the y-axis, you can see constipation and diarrhea. If you move up the y-axis, that's constipation. So patients with pain and constipation, that's IBS with constipation. But if they don't have much pain on the left upper panel, but they have constipation, that's functional constipation. If they have more diarrhea, less constipation, but not much pain, that's functional diarrhea. And if they have diarrhea and pain, then it's IBS with diarrhea. So this is really along a spectrum. Next slide. So now we know, we refer to functional GI disorders as disorders of gut-brain interaction. And that's because a lot of scientific evidence show that these are a group of disorders classified by GI symptoms related to any combination of the following: motility disturbance, visceral hypersensitivity, altered mucosal and immune function, altered gut microbiota, and altered central nervous system processing. Next slide. The IBS pathophysiology is really multifactorial. There's a lot of environmental factors that can increase the risk of IBS, a genetic predisposition or familial predisposition. There can be triggers like food, GI infection, inflammation, and then we can get disturbances in the gut-brain interactions, and we could have some gut peripheral abnormalities that can exist in IBS patients, like altered intestinal barrier function that is termed in the lay public as leaky gut. The bacterial flora can be altered, and the patients have increased visceral sensitivity and can have abnormal GI motility. Next slide. For treatment, there's really a graded response. You really determine first if the patient has mild symptoms, moderate, or severe. If the patient has mild symptoms, we want to give dietary lifestyle advice, give a positive diagnosis of IBS, and explain about the condition, why patients have it, and reassure them. Patients with moderate symptom have symptoms that really start impacting their quality of life. And in those patients, we do everything we do in the patients with mild symptoms, but we do continuity of care, manage stress if symptoms are stress sensitive, and we start using pharmacotherapy. For patients with severe symptoms where it's really severely impacting their quality of life, we do also what we do in mild and moderate symptoms, but we start introducing psychological behavioral treatments, continuity of care, central neuromodulators. Next slide. This just shows an overview of the IBS with diarrhea treatments. A lot of it is directed towards the gut, where we want to affect the microbiome. We may use antibiotics, diet, probiotics. If we think the patient has bile acid diarrhea, we may use a bile acid binding agent. For patients with more enhanced gastrocolonic response, meaning that the colon will contract or have more spasm in relation to meals, we may use an antispasmodic like peppermint oil. There are also 5-HT3 or serotonin type 3 antagonists that can reduce symptoms of IBS with diarrhea. And then we have opioid receptor modulators that work peripherally and can help reduce diarrhea and in some cases pain. And then neuromodulators can target the central nervous system as well as the gut and can reduce symptoms of IBS with diarrhea, like pain and diarrhea. Next slide. And then we have IBS constipation treatments, and a lot of them overlap with chronic constipation treatments, which is where patients have chronic constipation, but not really predominant pain. And we have a lot of gut-directed treatment like prokinetic agents that increase the motility of the bowel. We have pro-secretory agents that increase the secretion of electrolytes and fluid and could improve stool form and also can reduce abdominal pain. And then there's bulking agents for more of the patients with mild symptoms, stimulant laxatives, as well as osmotic laxatives. Next slide. We also have behavioral therapy options and targets. We know that this is a gut-brain disorder that can lead to more maladaptive responses where symptom-related anxiety, which I think is protective and completely understandable, but it can lead to more catastrophizing thoughts, a hyper aroused system where the patients could lead to difficulty sleeping, more stress sensitive symptoms, more activation of the cortisol system that we call the HPA system. And it could be more of altered central nervous processing of information, lead to amplification of symptoms. And all of these lead to pathophysiologic mechanisms that we can target with behavioral therapy, like gut-directed hypnotherapy, cognitive behavioral therapy, mindfulness-based stress reduction, and relaxation training. And a lot of these modalities can be used in concert with medications and also diet as well. So you can see that we're moving towards a more integrated approach of diet, lifestyle, medications, behavioral treatment, reassurance, education, and then establishing a therapeutic and successful patient-provider relationship. Next slide. So we really come to the biopsychosocial model that Doug Drossman really brought into the disorders of gut-brain interaction field, where we look at risk factors of early life environment, leading to psychosocial factors and physiologic changes in the gut and the brain and the interaction between the two, and they all can interact and affect each other. It leads to the IBS presentation of symptoms, comorbidities, and behaviors, and that can affect outcome. So I think it's important to look at the patient as a whole individual, think about the different factors that can affect their symptoms or the development of IBS and the triggering of IBS symptoms, and then target treatment that is really patient-centered and relevant and important for that patient. So thank you so much for your attention. And I know during the meeting, we'll have a lot of time to talk about the specifics. Thank you again to IFFGD.
Hello, my name is Deb Caton, and I am so glad to be a part of IFFGD's 30th anniversary edition of the Nancy and Bill Norton Patient Education Series. I want to thank Carolyn Eiler and the IFFGD for asking me to share my patient story with you today. If there's anything I have learned while living with a functional GI disorder, it is that while we may all share an understanding of living with it, each of us has a unique experience. I have learned that what works for one person will likely not work for another. This is a constant source of frustration for many of us. However, we have the ability to learn from and support one another through our struggles and successes. I've spent many hours, days, even years feeling quite alone in my struggles with my functional GI disorder, but I hope that sharing my story with you today will help you know that you are not alone. As far as I can tell, I was born constipated. No, my mother never told me that, but I can't remember not being constipated. I have vivid recollections of tear-filled episodes in the bathroom, my mom on the phone with the doctor, begging him to help me go. Once he suggested a suppository. 10-year-old me wanted nothing to do with that once I found out what it was. I've also always struggled with food. I am Greek, and big meals were common. This did not work for me at all. I spent most of my life hearing constant variations of, why don't you eat more? You're too skinny. You eat like a bird, from all of my family. I hated it. Apparently, they viewed my food intake like this. In reality, I ate all the time, and my favorite snack was ice cream with lots of chocolate syrup, but big meals just weren't my thing. I just ate small things all day long. Despite my apparent lack of appetite, I was athletic and always moving, and I was a gymnast for 8 years. When I was 8, I had a traumatic experience that impacted the rest of my life in ways that I'm only recently fully understanding. On a family trip to Florida, a girl vomited all over me in the back of our car. It was a complete nightmare. And from that, I developed what I now know is called emetophobia, or a fear of vomiting. During college, my GI problems reared up again. I was so constipated that I would tear and bleed when I tried to have a bowel movement, and I developed hemorrhoids that were very painful. I also started to feel sick quite often, but I could not figure out any one cause. I didn't ask a doctor or my parents for help. Instead, I started trying to fix it myself. I decided that drinking pop was giving me stomach aches, so I stopped drinking it. Then I started self-medicating, carrying around a bottle of Pepto-Bismol to drink when I felt sick. Nothing made it better. I just figured this was how my life would be. Around 2005, I began to feel bloated and sick after eating even a small amount of food. So I finally saw my very first GI doctor. He determined that I needed my gallbladder out and that I should avoid red meat and fatty and fried foods. He also gave me my first official diagnosis of IBS. He did not say what subtype, nor did he offer much in the way of solutions. Things did not get better. Over the next 10 to 15 years, I began to slowly feel worse and worse. The episodes, as I came to call them, became more frequent. Constipation, diarrhea, bloating, then periods of feeling fine. I kept functioning though, not seeking answers from doctors or anywhere else. I also experienced increasing anxiety. I sought counseling on a few occasions and started taking an antidepressant. It helped my anxiety, but I still did not seek help for my GI problems. My episodes got steadily worse and more frequent. For instance, on a trip to Arizona in December of 2018, I spent most of one night crouched on the hotel bathroom floor, sweating and shaking, nauseous and scared, praying I would not vomit and that it would just go away. Through the next year, these episodes became more random. They would appear out of nowhere in the middle of the day or wake me out of a sound sleep. I was getting scared. So once again, I decided to work on finding my own solution. In July of 2019, I stopped taking my antidepressant after 10 years. I thought maybe it would help. It didn't. I also discovered the low FODMAP diet and figured eliminating possible trigger foods might help. It didn't. By September of that year, I began to lose weight and I went to see my second GI doctor. I had a colonoscopy that showed no organic problems and was told once again that I had IBS and to manage it with diet. By October, I had lost 5 pounds and food was a constant stressor. I was afraid to eat, but not eating wasn't helping me feel less sick. Finally, in January 2020, I called the University of Michigan GI department. Their first available appointment was at the end of March, but because of COVID, my new GI doctor never saw me in person. He started me on some medications, including Remeron and Linzess. Based on my symptoms, he said that I likely had IBS with constipation and pelvic floor dysfunction. I had never heard of that before, but he was right. During May of 2020, I had another colonoscopy, an EGD, an abdominal CAT scan, and an abdominal X-ray to try to figure out what was wrong. At the end of May, I went to the emergency room because I discovered, severely constipated. I stayed for 3 days and had an anorectal manometry study and a defecography done. Those tests showed that I definitely had pelvic floor dysfunction. Pelvic floor dysfunction is the inability to correctly relax and coordinate your pelvic floor muscles to have a bowel movement. The next several months are kind of a blur, but by June, I had dropped to 80 pounds. I was severely malnourished, constantly sick and in bed, and generally not functioning. I could hardly eat, and even when I did, I felt sick and feared vomiting. I was emaciated and struggled to do basic things like shower or cook or clean. I was frustrated and depleted and scared. I kept thinking I could handle it, that it would somehow get better, but it didn't. Every aspect of my life was impacted: my work, my parenting, and all of my relationships. Finally, on June 25th, 2020, I checked myself into the hospital. I was there for a week. While I was there, I had many tests done, including a gastric emptying study, and I had an NJ feeding tube placed. This fed right into my deepest fears of vomiting because they thread the tube up your nose, down your throat, through your stomach, and into your small intestine. The next week in the hospital was one of the hardest of my life. I cried all the time and my body did not like the liquid nutrition I was receiving, so I felt sick constantly. I spent the next 7 months on a 24-hour liquid tube feed, which provided enough calories to survive. My weight gain was incremental and painful, and I had to have the tube replaced 3 times. I spent most of these months with what I came to call my team of doctors, including my GI doctor and nurses, a dietitian who specializes in GI disorders, physical therapists, a GI psychologist, a trauma therapist, and a psychiatric nurse practitioner. I had a new mini pharmacy of medications, and in August, I slowly restarted the antidepressant, which helped immensely. Apparently, stopping it in 2019 may have led to the worsening of my IBS-C. I learned that our guts have more than 30 neurotransmitters and that 95% of the body's serotonin is found in the bowels. I learned about the gut-brain axis and practiced gut-directed hypnotherapy. I also began 5 months of biofeedback and pelvic floor physical therapy. I slowly relearned how to eat solid food, though I often felt terrible. There was no such thing as a good day, only less bad days. In early February 2021, I reached my goal weight and weaned off the tube feed. Happily, I maintained my weight and had my tube removed on March 3rd. I still have a long way to go, but I continue to heal both physically and mentally. I can't easily summarize all I have learned over the last 18 months, but I will try to hit the highlights. First, I have learned how small your world can become because of your functional GI disorder. We likely have all experienced this in one way or another. It's not easy to begin to expand my world again, but I work on it daily. I've learned that you need to listen to your body, especially when it comes to medicine. Instead of jumping into full dosages of medication, I started small and built up, and it helped me so much. Along with this, I learned patience. I've always had high expectations of myself, but I've learned to slow down and give myself credit for what I have accomplished. I've learned to seek out valid, reliable, research-based sources of information, including organizations like IFFGD. I've also learned that whenever possible, we should find and enlist the help of qualified professionals instead of trying to fix our GI disorders on our own. We must keep looking for people who will truly listen to us and understand that the answer may need more than a handout and have the knowledge and desire to find answers and resources. I have learned that you must advocate for yourself, sometimes loudly, to ensure you get the best care you can, to be heard and to be understood. Perhaps most importantly, I have learned that I'm stronger than I ever realized. I did not get to where I am today alone, and I will be eternally grateful to my family, friends, and innumerable medical professionals who helped to get me here. But I made it through situations I never thought I could, and I'm stronger for it. Having and living with the functional GI disorder is part of who I am, but I believe I don't need to let it define me, and I'm hopeful about making my life bigger than it has been for the past few years.
Hi, everybody. My name is Lisa Strykowski. Thank you so much to IFFGD for allowing me to share my IBS-C patient story with everyone today. So I started off fairly uneventful other than infant reflux. My poor parents who had a newborn that would projectile vomit. That was my biggest problem as a child in regards to gastrointestinal distress. I outgrew it and had a fantastic childhood and teenagehood, doing all sorts of cool things. I had no limits. I could travel. I could do everything that I loved, had no problems. That all changed around 1999. I started to experience stomach problems. I had a lot of loose stools, stomach aches, cramping, bloating, urgency, tiredness, migraines. My gut would flare up a few times a week, mostly in the mornings. My 15-minute commute to work would include 1 to 2 bathroom stops along the way. So I learned to travel with my little bag, as you can see in the picture, that had all sorts of supplies in it, including medication, extra toilet paper, extra ointment. Let's just say it would just get a little awkward at security checkpoints at some places. So that went on for a few years, and around 22, I finally mentioned my frequent stomach aches to my primary care provider. I was told that I probably just had IBS and that I probably just had nerves that went to my gut. Over-the-counter anti-diarrheal medication was fine as needed for my symptoms. I had blood work done. I tested negative for celiac. At the time, this was only offered as a blood test. And I started taking over-the-counter anti-diarrheal medications as directed. And I also got a prescription for zolmitriptan because I was also experiencing migraines with my stomach ache. So I was taking 4 to 6 milligrams of loperamide daily after a while. And around 27 years old, so 8 years after my symptoms started, I reached out to my primary care again because the amount of medication seemed excessive to manage these symptoms. So again, I tested negative for celiac. I was finally referred to a gastroenterologist, had a colonoscopy, and was told again that it was quote unquote just IBS. Around the age of 30, so that was around the year 2010, my gastrointestinal disorder kind of leapt up, got a little more intense. Around the age of 30, I had my gallbladder removed, and I had a gallstone the size of a golf ball that was found 5 years prior when I was pregnant during a routine ultrasound. It had flared up. I had my gallbladder removed, and that actually took away so much of the pain that I was experiencing because of where it was radiating. It was just assumed it was part of my IBS symptoms. So that felt so much better. I was still taking loperamide daily. And when I was around 32, I actually had a really bad case of acid reflux. And when I went to see the ENT that I was referred to, he looked at my chart and he was the first medical professional to suggest that based on my symptoms and medication, I had either a food allergy or sensitivity. I visited with an allergist, and they were the first to suggest that even with a negative blood test for celiac, I could still have a sensitivity to gluten. And they suggested that I give it up for a little while, which I did. My gut health improved tremendously. I no longer had migraines, so I didn't need the zolmitriptan anymore. However, I did keep the loperamide on hand for those occasional IBS flare-ups. Around the age of 36, I started to develop an intolerance to the loperamide, severe stomach cramping and constipation after taking even a small dose of the medication. So I tried to take it as little as possible, but I was either at one end of the spectrum or the other. I was either having an IBS-D flare-up or I was having severe constipation. And either way, it just was not working out. So I tried to keep taking the smallest dose possible, but eventually I had to stop taking the loperamide. So by this time, my IBS-D had flared up with the worst symptoms I've ever experienced. It lasted for about 3 months. So 2 months into that, I was just kind of waiting to see if it would get better. I would, because it had never lasted that long before. I would go to the bathroom before I left for work, race to work with my 15-minute commute, and I'd be hitting the bathroom again really quick. I had to plan my entire day around a bathroom. So again, after 2 months, it just kept going. It wouldn't let up. So I reached out again to my primary care, and I was told not to take loperamide anyway, because I needed to let whatever needed to come out. A new medication was available for IBS-D, but I couldn't take it because I no longer had a gallbladder, and I would risk the chance of getting pancreatitis. So I was referred to the gastroenterologist that I saw originally for my colonoscopy almost 10 years prior. And I was prescribed amitriptyline, which is originally an antidepressant, but because they were starting to see that maybe there was a brain-gut connection, a brain-gut misfire, that this would actually help. And it did. It helped tremendously at first, but eventually I started getting panic attacks from the medication. And I kind of figured, is medication no longer an option for me? Even though I hadn't tried many, I didn't know if I wanted to try more. So I weaned myself off of the medication and started looking for a new approach on my own. As you can see, a little bit of humor here. I would always go prepared everywhere I went, and I had a lot of time to think. So I thought back to when I gave up gluten and I felt better. And I thought maybe I should start looking at what's causing the symptoms and stop looking at treatments. And so I thought back again and I thought, well, no one had suggested nutrition other than gluten for me. So I thought, well, let's try looking at nutrition again. So I went online, searched around, and I found the FODMAP diet. As a disclaimer, if you have access to a nutritionist, I highly recommend doing this with somebody as support, someone who can guide you through this process. I did this on my own. I eliminated all of these foods from my diet, reintroduced them a little at a time, logged all of my food choices, my reactions, and I found that I had additional food sensitivities. So in addition to the non-celiac gluten sensitivity, which I have to avoid wheat, rye, and barley, I could also no longer eat legumes. Beans, chickpeas, lentils, cashews, and peanuts were now off the list. Anything made from legumes, including peanut butter and hummus, and also peanut oil. Again, I do recommend working with a nutritionist because I did find that while these foods were triggers, I didn't consider products made from them as well. So they can help guide you through that process. I also had to now avoid raw apples and pears as well as corn kernels. So moving ahead, before and after FODMAP, I started FODMAP on April 5th of 2017. A year and a half later, after following FODMAP restrictions, adding intermittent fasting to my diet, and focusing on a diet with high protein, low carbs, and good fats, July of 2018, I was doing my first fitness shoot. Please do not be, it's a bit of an illusion here. I did intermittent fast the day before. And again, as you can see, some days, May of 2018, I was, nice flat stomach. June of 2018, I had my food baby. So even now today, even though my symptoms have improved, they are not cured. Some days I am Lisa on the left. Some days I am Lisa on the right. My flare-ups are less frequent. They're shorter in duration, but I'm still managing with only nutrition after 5 years of this journey. I'm still avoiding those trigger foods. I do try them periodically. They do still bother me. I still experience occasional and mild flare-ups, gas, bloating, and urgency. And again, it's been fairly consistent for the last 5 years with only nutrition. So that's my story. Thanks again so much for IFFGD for having me today.
Hello, and welcome back to the Norton Educational Series 30th Anniversary Edition. My name is Cecile Rooker. I'm the President and Executive Director for the International Foundation for Gastrointestinal Disorders, or IFFGD. Thank you for joining us today for this very special anniversary event where we are learning about all sorts of GI conditions and topics related to your digestive health. We do apologize for the chat incident through the last session, and we have disabled the chat so that you are not going to be able to chat with one another. However, if you use the chat feature, that will be sent directly to IFFGD. We will be cataloging any questions or comments that you do send in, and we will be able to address those during these moderated host sessions. So please do keep your comments and your questions coming, because we will be able to address those. We will just not be able to make them public for viewing until we can make sure that we don't have any more interference. So this was a great session, Lynn. Thank you so much for your physician introduction to irritable bowel syndrome. Obviously, I mean, as your presentation said, it affects so many people. It's really high prevalence and is really something that is of a severe concern to so many patients. So one of the things that you mentioned in your talk was the word organic. So can you define the word organic for us?
Every time I write that, I have to pause because, the classic way that we think of organic is that you have to find something biochemical, structural, anatomic that will explain the symptoms. But as science is progressing, we are finding physiologic or biologic explanations for the symptoms. So every time I say that, I think I mean it in a classic sense, like having inflammation that you can see in the bowel, like inflammatory bowel disease, or clearly celiac disease as organic diseases. But you can really, IBS is an organic disease. It's just not in the classic sense.
Okay.
I guess that's why I would put it.
And you talked about behavioral therapy, and then of course both of our patients alluded to that as well. So, what percentage of your patients, each of you, do you think were you referred to behavioral therapy with irritable bowel syndrome?
Well, I work in a tertiary care referral center, and so most of the patients will have more severe symptoms. And with greater severity, there's more difficulty managing the symptoms. And so many patients could benefit from behavioral therapy. And also there is a coexistence with psychological symptoms, and they can benefit from that as well. So for me, I would say over 50%, but not everybody probably should be referred to behavioral therapy. And I've learned that from our GI health psychologist. And John, you probably have the same, situation. So because it really is a gastrointestinal skills-based approach. So if there is maybe not as well controllable general anxiety or depression, many times it's recommended that they should get treatment for that. And then later on be more suitable for a GI skills-based approach.
Okay.
You know what I mean, but it is very helpful for stress-sensitive symptoms and for catastrophizing, where you can anticipate some negative events happening that with your symptoms. But no, I don't know if everybody at that time is the right suitable candidate, but a majority definitely.
Fantastic. And what about you, John?
Yeah, so in the esophagus, we're probably about the same rate, I think, if you look at the group of patients that we see at a tertiary care center. But similar, I think even people with organic disease can benefit from behavioral therapies because it really allows you to shift your attention to more positive things. You don't perseverate on the symptoms and you don't let it rule your life. But for us, the patients who come in with heartburn that's not related to overt reflux, they don't have inflammation on their endoscopy, they don't have horrible acid reflux on their pH testing or their reflux testing. These are patients who I can feel comfortable reassuring them that they're not going to injure their esophagus. And I think reassurance has a huge power when we present it that way, that you're not going to hurt yourself by not being on an acid medicine. And then what we need to do is shift your attention away from those symptoms. So for us, particularly in the esophagus, we really like cognitive behavioral therapy, and we also like hypnosis. So hypnosis is something that we do a lot of, and getting patients to think along those lines about shifting their attention. So we use it a lot.
Fantastic. So we actually had a question from someone in the audience, and they were asking if you had found experience with helpful to have people do relaxation techniques with Globus.
So Globus in particular, we've had a pretty good effect with. In fact, hypnosis for Globus, we've published papers on this, 75-80% response rates in these patients where, they visualize, an ice cube melting in their throat, and this kind of relaxes that area and just shifts them away from that sensation. And Globus probably is a physiologic event that we're just not able to really appreciate. But it's something that I think we can characterize and we can educate patients. And yeah, they essentially relax to the point where they don't care about that particular thing anymore. It's probably still there, but it's not as important and it doesn't affect their quality of life as much.
It's not even just shifting, right? It's reframing the way you're perceiving your symptoms. Because it's not like you don't want to even think about your symptoms, but instead of thinking there's a blockage or there's fire here, having that cooling sensation. So it's really reframing how they're viewing it rather than completely distracting them. Although distractions to some extent part of the intervention.
Yeah, and I do think, teaching patients how to self-manage too is extremely important because, a lot of these things we can't fix completely, and accepting that we can't fix them completely and that we have to, in parallel, try to improve the symptoms while we're trying to work it up and figure out what's going on. But more importantly, kind of saying, okay, well, let's work around this. You've identified triggers, you know what's going to happen and manage that yourself. I think it's empowering for patients to be given those cognitive techniques and abilities to deal with the symptoms.
I also think that, a lot of times we see, as a healthcare provider, we see the patient for 15 minutes, an hour, whatever the period of time.
Yeah.
But the other 24/7, time, they're in a different environment. And I think to understand what they're experiencing and applying that behavioral technique or just the reassurance or the education is really important because that's most of the time they're going to spend. So we get a snapshot view at that moment, but it's really important to try to understand what they're experiencing most of the time, which takes time and a lot of reflection.
Fantastic. So you mentioned tertiary care center, both of you. And so Northwestern UCLA are tertiary care centers. Can you just really quickly tell us what that means?
Usually it's patients that have already seen primary care physicians and have even seen community physicians like community gastroenterologists, but they usually are requiring or seeking more specialized care. So often, like Northwestern definitely has a specialized center for esophageal disorders and GI, and UCLA also for different conditions. So it's really more an expertise level of care, but it tends to be patients with more severe or refractory symptoms.
Fantastic. And for those of you at home, if you're looking, thinking maybe it's time for you to visit a tertiary care center, please reach out to IFFGD and we'd be happy to help you to try to find one in the disease state area that you are looking for. So back to irritable bowel syndrome. And this is all great conversation. And we appreciate the questions and obviously appreciate both of your time. So if you're seeing someone for the first time and we've got a suspected IBS patient, what are some of the key symptoms, key things that these patients should be talking to you about in that initial consultation to get the right diagnosis for them right off the bat? What are the important things that maybe people forget to tell you that you wish they had told you up front?
I think it's always good to start off as open-ended and not be so, not so many of these yes/no questions. Because if you start off more globally open-ended, then you can really figure out what the patient's coming for you for. So I usually will say, what brought you in here? What during this time do you want to make sure we address? And I always think it's good to address what's the most bothersome symptoms, which are usually always the symptoms that impact their quality of life the most. So I really want to get at is what they're seeking. Some patients are just saying, I just want to confirm the diagnosis. I really want to just use some lifestyle or dietary modification. I don't really want to go on a medication. And then there's other patients that really want you to explain things, or they said, I want the pain to go away. So I really try to get from their perspective, what is it that will be helpful for them? And, if they want to start on a certain topic, we'll go there because I think that's really important. But I try to just get the symptoms assess the symptoms so that I understand what the diagnosis is. I actually don't find that to be the hardest part. The harder part for me is, or the more time-consuming part, is trying to understand the illness behavior, the way they're managing their symptoms, any coexistent conditions, what have they tried before, what are their expectations, how do they think about their condition, because that's the way that it should be approached, and every patient is different. So to me, that takes more time, but I think it's a really important part.
Fantastic. And John?
Yeah, I think, what Lynn said about the symptoms, for me, I don't think patients care so much how many times a week they have heartburn. It's more, well, can I go out and enjoy a meal with my family without the fear of being embarrassed? For us with swallowing issues, the other thing is choking. So people may say, yeah, I get food caught, but that's not really what's bothering them. What's bothering them is when they're sitting home alone and they're scared they're going to choke and may go unconscious. So a lot of what we focus on in those initial interactions is not like, do you have this symptom, how many times? It's more, how is this impacting you and how does it affect your ability to live a good quality life? And I think that's the more important thing. And that's why being open-ended is really helpful.
Right. And for patients to understand that maybe starting with that in the beginning, I'm here because this is what I'm worried about. This is what's impacting my life. And then moving into the questions. That's fantastic. And definitely great advice for all those people watching at home. So what about daily diaries? So you hear a lot about that. Is that helpful? Not helpful?
I think it's very helpful for a patient to understand what symptoms they have and what makes it better and what makes it worse. And sometimes it's hard to remember like what you ate 2 days ago, you know?
I don't think I could.
So it's helpful for them to do it real time. But to always include the most bothersome symptoms, the severity, and what factors potentially could trigger them. So when you're looking for flares, you know, you want to see what started their symptoms for the first time or what triggers their flares. I think it's important. I do think, though, that it's good to do it for maybe a set period of time, maybe 2 to 3 weeks
Yeah.
to get a good assessment. And depends how frequent their symptoms are. And if they're going to start a new intervention, I don't think it's probably great to do it all the time because then it gets you a little too focused on the symptoms. But it's helpful. It can be helpful for different reasons.
That makes sense.
Yeah, I mean, we use diaries a lot in the esophagus because most symptoms are triggered with food. And we always try to find those triggers. But I agree, we don't want that to become the sole focus of your life and have you keyed in on that, because that then becomes something that propagates hypervigilance and can make you worse. So we really try to be a little bit more lenient and for short periods of time directed. Okay, we've changed this intervention. Let's see how it works. Okay, it's better than before, but certainly not something that we want you to do every day the rest of your life.
But you know, I think it's important about daily diaries for patients is that they should look at the diary and they should look at the associations and the fluctuation and the triggers. So I usually say to them, well, when you looked at it, what did you learn from that? Because this is all about empowering the patient for self-care.
Right.
You know, not for them to say, well, you're the doctor, you should look at it and tell me. I will tell them, but I want them to look at it too, so they learn how to manage their symptoms. And I think that's really important.
Absolutely. That's part of advocating for yourself.
Yeah.
And really learning how to do that. So, so what I'm hearing is 2 to 3 weeks. Probably good to do it right before your next doctor's appointment so that you can come in fresh with this is what's been happening for the last few weeks. And
Yeah.
then, moving from there. Fantastic. Thank you so much.